Hello, everyone, and welcome to our latest webinar, supported by Surgery International and with our sponsors, the Confederation of British Surgery and Medical Events. So this is the fifth in a series of global webinars that we're trying to produce to really educate and bring together a community of surgeons around the world. Surgery International was set up with that primary aim, to build that community, to have the conversations and showcase who we are across industry and, of course, across our profession. Our webinars at the moment are covered on a wide spectrum and across the world. Today, we have 500 registrations across 40 countries. In total, Surgery International has 18,000 subscribers across 140 countries. So we really are building that community across the globe to share and discuss the concerns and the dilemmas and also the innovations taking place in our world of surgery. So this is a leadership webinar, and we have a stellar panel, of course, to discuss what leadership might mean for the surgical profession. So I'm going to ask our esteemed guests to present themselves with a short history about who they are and also about the experience in surgical leadership and, of course, management. We'll start with our fellow surgeon, Mark Slack. Mark, tell us a bit about yourself.
Shafi, thanks so much. So I'm a surgeon by qualification. I was an academic surgeon at Cambridge University for most of my career. I was a gynecologist by definition. I came from my original country of South Africa to do research in Cambridge and forgot to go home. I've also done quite a lot of inventing in the past, and I've sold some of my ideas to major international companies like Johnson & Johnson. But I more recently then decided that robotic surgery might be a good idea. I didn't like what was on offer, so I started a company to build a new robot to introduce robotics surgically, and it's grown quite big. It's now a unicorn with a valuation of about 3.4 billion, and we are building a robot to try and increase minimal access surgery. So that's sort of me in a nutshell.
Thank you. And I think South Africa's loss is the UK's gain, I might add, Mark. So I'm glad you decided to stay in our humble country in England. Going across the pond to the US, Jamie, tell us a bit about yourself.
Thank you so much, Shafi. It's great to be here. My name's Jamie Robertson. I am across the pond in Boston, Massachusetts in the US. And really my background, I come in as a research scientist, so I'm not a surgeon and I don't do any clinical work, but I like to study surgeons because they're fascinating to get to understand what actually goes on in the OR. So I started out working in surgical simulation and have really grown from that to think more about how do we educate surgeons to be better leaders, to be better followers, and to be good team members in and out of the OR, which is what I do for Harvard Medical School, as well as for Brigham and Women's Hospital here in Boston.
Thank you, Jamie, and thank you for what you do for surgeons. They're not the easiest group to manage, I assure you, but thanks, no doubt, for your endeavors in helping us with our own leadership in our profession. Nora.
So my name's Nora Colton. I'm the director of the Global Business School for Health at UCL. We were set up about 3 years ago to bring a different perspective on leadership and management in healthcare. Myself, I'm a professor of leadership and management, and the real impetus for the school was the fact that we need business and management skills, not just clinical skills, to really take on this new health economy that we're all facing today. Rapid change, of course, one of the major drivers of everything we're doing is around technology. So this is an area I feel really passionate about, and particularly in terms of what are the kind of leadership skills that we need to really instill in our surgeons as they confront this new environment. Very good for patients, but if we don't have surgeons with the right mindset and practices, much of the technology can go to waste.
Thank you, Nora. And Denise.
Hi, everyone. I'm Denise Cafarelli Dees, and although I have a very strong American accent, I'm actually talking to you from the UK side of the Atlantic. I did start my career in the US as a clinical scientist by training in communication disorders, and I've worked in hospitals on both sides of the Atlantic, mainly working in ENT departments, and been involved in surgical training from those very early days up until the time I jumped ship from the NHS into the corporate world of medical devices and hearing implants. And this experience and working with surgeons led me to work more closely with Healthcare Skills Training International here in the UK, and setting up a leadership course that was accessible to introduce these vital leadership skills to surgeons.
Thank you, Denise, and thanks for joining us this evening. And thank you all for joining us. What a stellar panel. Where do I start? I think what I will start straight away, I think with you, Mark. Why do we need to build leaders in surgery? In the past, remember, we kind of did what we like. You know, we were powerful in the hospitals, and when we were training, for example, leadership wasn't really taught or thought to be necessary. What's changed? What do you think, Mark?
You know, leadership wasn't taught at all. And in fact, everybody was an individual and everybody knew the best, according to who they were and the strength of their personality. And medicine's had a couple of really bad examples of lack of leadership, leading to really adverse outcomes for patients and for the community as large. And I think what we need now is a leadership community that understand the concept of being supportive, being results orientated, you know, listening to different perspectives. When I was a young doctor, the only opinion was the senior doctor's opinion. Nobody else had a say, and people who have effective problem solving. So the really big change, I think, is that you know, with data, with the connectivity that we have in the world, people are understanding where things fail, and medicine has failed badly in some areas. And what we need now is really strong medical leadership to put things back on track and actually go forward.
I think you're right. I mean, we've encountered many situations in the UK and, of course, in the wider world around where failure of leadership has led to bad patient outcomes. We're all here, of course, to improve patient outcomes to the best that we can. And when patient safety is compromised or patient outcomes, it's obviously difficult for organisation in that sense. So I think you're absolutely right. And the NHS has had some bad experiences more recently, the Miss Staffordshire crisis and others, that has just demonstrated not just lack of leadership, it's also about communication, team building, etc. Jamie, from your perspective, obviously you've been teaching and running the surgical leadership program at Harvard. What have you learned over the last few years since taking that role on about where surgeons are coming to, why they're interested, is there a huge interest, and what do they leave from going on to your leadership program?
Yeah. So we've been running the Harvard Medical School Surgical Leadership Program. That's a one-year certificate course since. It started in 2018. And so we've been running these sort of one-year cohorts since then. And I think why people come to the program is really that they're looking for those skills that weren't part of their surgical training. So we teach a lot of finance. How do you balance budgets? How do you figure out how much stuff is going to cost you? How do you manage property and people and all of those things that are an important part of running a hospital or a department or an entrepreneurial enterprise? We talk a lot about management of both yourself. So how do you develop your leadership skills, but also how do you manage employees, not just those in the OR, but those that are outside of the OR. And then we spend a lot of time also just working on thinking through those skills in business case discussions, some of which are specific to surgery and some of which are looking at more broader topics that then you can utilize those things and apply them to the medical setup. And so I think people really leave the program thinking about how do these apply to becoming an administrator or an entrepreneur, and how can they then go beyond applying patient safety practices in their OR, but applying them outside of it? How do they make good proposals to the administrators, to the C-suite of people that are going to be accepted and implemented, and then help to sort of create those systems that protect their patients?
Yeah, and it's quite a unique program globally. We don't really have a particular course just for surgeons generally. Now, of course, Harvard started this, 5-6 years ago. I was pleased to be on the faculty the first few years, teaching about innovation. How many candidates do you have per year out of interest? Has that expanded since you've been there?
Yeah, it has expanded quite a bit. And then, so we've had probably initially around about 100 people that we take per year through the course in 2 cohorts. Typically, one is based in Boston and one is based in London, to allow for a little bit easier access for folks to things like in-person workshops. But this year especially, we've seen a big growth in the number of people coming in. So we're at a little bit over 100 this year. We do try to keep our numbers somewhat small so that we can get those personal attention pieces from faculty. But we've seen an extra demand for it over the last couple of years, where people are really starting to think surgeons don't just belong in the OR, they belong administrating in hospitals, in health systems, and thinking about those, building new robots and taking advantage of things. And I think people are really excited about it and excited to think about, what skills did I miss out on in medical school that they were teaching in business school that someone knows that I don't?
Yeah, no, I think you're right. The role of clinician across the board is changing from being hardcore clinician to having those other skills, including soft skills, management skills. And in the past, I'm sure Mark would agree, when we trained to become surgeons, we're very much operators and we're defined by our role as a surgeon. Yet many of us decide to take leadership positions with little or no training. And it's only recently become more of a science and more investments being put in to leaders to build their skill sets going forward. It's not an innate ability that we have, but we have to learn it from others. And of course, we've seen that much more being supported. So taking that to the absolute extreme, it's absolutely delight to have Nora on the call here today. So Nora, as you mentioned, has built the very world's first global business school for health. And so congratulations, Nora, on that huge mission and kind of where you delivered a new business school for the world. It's been around for 3 years, I understand. I'm lucky enough to occasionally be asked to teach on the course. And we're meeting leaders from around the world. So Nora, let's take that to the extreme around leadership and what experiences have been over the last 2 or 3 decades around where the lack of leadership has led to problems, and how you think by coming on these courses or getting the skill sets right, we're able to have a better healthcare system. I'd get more of your thoughts from your academic role and also what you've seen over the last few years in building this new business school.
Well, thank you, Shafi. I think this is such an important topic. As I mentioned in my introduction, technology is driving so much of the changes that we see in healthcare. And when we talk about surgery, we're not talking just about the operations or the operating room. We're talking about, the pre-op, the post-op, and the kinds of people that we're employing now in our healthcare system are changing. So one of the key aspects of the Global Business School for Health and the way that we approach our mission is to really equip the next generation to build those skills and think forward. So how's AI, how's robotics, how's data science really impacting surgery is an important topic. And for me personally, I think even within the leadership and management domain, we've spent too much time focusing on the individual. And we need to really shift that narrative now to much more about teaming and teams. So, if I look at some of the early literature, that came out in around the 80s and by people like Richard Hackman, they really focused on this notion of structures. Get your structures right. design, make sure you got the roles right. And no other profession has been so fabulous at doing that than healthcare. Very hierarchical, everybody. So, so we talk a lot in healthcare about multi-professional teams. But what we don't talk enough is about integrated teams. How do we get these people to really integrate and work as one? And, when you're talking about technology and really putting it at the forefront of what you do, that has to be because there's a certain amount of control our surgeons have to give up. So for our patient safety, for a better patient experience, and a brilliant study was done on cardiac surgery and looking at the role of the surgeon. And it shouldn't really surprise you that those individuals who were able to really change the narrative, create and construct a different kind of framing for the leaders. So, those surgeons who came in and were really about their individual expertise versus those who came in and really thought about the expertise of the team and about how do I bring these people together. The team itself, whether or not that surgeon was empowering them, respecting them, realizing how integral they were. Versus those who were just focused and we've all known these people, right? Technical skills, clinical skills. I'm going to use this robot and I just need my team, skilled up on the technical side. Those individuals who stayed with that historical narrative tended to have more issues, failures using robotics and technology. Those people who took that different kind of mindset saw leadership as flexibility, as collaboration, as listening and letting their teams speak up, had much bigger successes. So that's really, for me, at the heart of everything we do at the Global Business School for Health, because I believe the future, and I often tell those in my classrooms, the days of being the lone wolf, of being the person who's number one, who's really at the top of your game, those days are over. Actually, the people who will succeed, and surgery is definitely one of those areas, are going to be the team players, the team leaders, the ones that can really inspire and transform those teams. So this is something I feel very passionate about, and I think we need to tweak the way in which we go about teaching leadership and management. We need to, of course, reflecting and thinking about oneself is important because that's part of the journey of being a good team leader. But we need to also start to put the emphasis right so that we start to signal and nudge those in using technology in particular and working with these new experts who will, help define a successful surgery.
Thank you. There's a lot to unpack there, of course, around what that might mean as we go forward. But I think you're right. The days, the maverick surgeons we used to call them, have been long since past. And now we're being found out because, of course, it's about teamwork. You mentioned integrated care, integrated teams, absolutely. And having that kind of ownership, accountability, all the things that we're now seeing much more commonly. And the surgeon has become an interesting beast. It's a multitude of kind of faculties that are required to build on what you have already, to be able to even lead as a surgeon in the OR, but also to work much wider and go up the management tree as well. So there's a couple of things to think about. Denise, you've come from also an industry as well, from EdTech and other companies. So tell me about your experiences of what you've seen from a surgical perspective, how we've been performing, and how you've gone about solving some of the issues that you might have come across.
First of all, I have to say I'm very encouraged listening to my fellow panelists because I think this is an exciting time. And working with surgeons from the industry perspective has given me sometimes cause for concern when there is this hierarchical maverick surgeon trying to bulldoze changes through and forgetting the basics of leadership. So what I've learned in my experience is that leadership isn't a one size fits all, which is why I'm very encouraged by what we've heard so far. It's almost like an onion, and you've got some of the core leadership skills that we still can't forget. And I think being able to lead effectively a single patient, and even those skills aren't always developed well enough in medical school and on the surgical training rounds, to being able to lead a team of clinical leaders or surgical leaders. So I think we still need the basics. That's what I've picked up from my working in industry, pushing through new technology, new innovations, new patents, working with individual entrepreneurs in the different hospitals, is making sure that they fully understand change management. But to get change management, I have to put my communication skills hat on, and which is a core of leadership, a human factor that we can't forget. And at the same time, communication problems are still time and time again, report after report, study after study, the major cause of medical errors. So we can get technical training in all we like, but if we don't have some of these core skills that we have under the umbrella of leadership, we will still put patients at risk. So communication, situational awareness, gathering the information, identifying, adjusting, and then responding, decision-making, making sure you make good decisions, and then adapting the leadership style to the situation appropriately, and then binding and going through the right programs so that you can set up the teams that you need to empower.
Thank you for that.
So, thank you.
Mark, coming back to you from a clinical perspective, so you have, say, doctors that come through the system, nurses, physios, everybody else. Let's take surgeons, for example, come through the system, whose basic talent is to be a surgeon, i.e. to learn the operative skills, the science behind it, and we work quite hard in defining that role. But then, of course, some people select themselves to become leaders. Some people might get training, etc. Is leadership important for every surgeon to embrace? Is that kind of what we need to do? Or do we just select a few people and teach them the skills necessary to lead others?
Yeah, I don't think every surgeon needs to be a leader, and many need to be followers, which is quite a difficult concept for many of them to actually embrace, because by personality, they all want to lead the game. But it's very important that you have genuine leaders who are willing to embrace the changes that are needed and are also willing to call out poor behavior. You know, when we train people with my company, we train a team. We never train a surgeon on their own. We train a surgeon plus their anesthetist plus their nurses. And we encourage them to think from the beginning that you're a team working together, because the individual being the prima donna is really quite dangerous. And in fact, if you look at the UK at failing surgeons, there's almost a physical characteristic that matches them. Yeah. They are tall, charming, private school educated, well-spoken, affable, and so on. And people totally trust that image. And, you know, actually, you know, the short, fat, possibly colored individual that makes one mistake will be drawn into the GMC quicker than the tall, charming, well-educated person. So, you know, we need leaders now to embrace this concept that there's difficulty going on in medicine. And I think leadership in medicine should be expressed through observable behavior. You know, the leader should be somebody who listens, somebody who's empathetic, somebody who's willing to hear change, somebody who's willing to be challenged, because there is no one way to do everything in medicine. And so I would like to see leaders lead by example and actually really draw people in with them, but from the point of view of being outstanding in their own quiet way. And that doesn't mean being loud or being, you know, the best in the world, but just being somebody who thinks and leads the group towards betterment of an entire team.
Thank you. Denise, you have your hand up.
Yes, Mark, I'm going to have this kind of fine point with you. I think I can sort of agree that not every surgeon will be the leader of a team, but I think that every surgeon needs leadership skills. They need to be able to, all the things you've just described at the very end are the very skills, the listening that a surgeon needs to lead a team around their individual patient. The listening, the asking open questions, making clear decisions, the situation, all of that is important. And those are leadership skills. Whether they will manage a team is the other part of the scale, perhaps. Maybe that's where we can agree. But I think every surgeon needs leadership skills developed.
But Denise, does it have to be the surgeon that has the skills, or could it be somebody else in the team? So the surgeon might be technically the perfect individual to do the operation amazingly, working with a multidisciplinary team, but it might be a different practitioner who leads the team, who drives the standards, who makes sure that you actually have the appropriate risk management, etc. So yeah, I think the mistake has been that the person operating is always in charge.
Who's going to talk to the families? Because I've sat in a number of places and there have been some surgeons, and I'm thinking, you didn't get at all what this family is about. And errors have been made. 66% of medical errors down to communication problems.
Yeah, sure.
I think just Jamie.
No, I mean, communication is a completely separate issue as well. So I largely agree with you, Denise. I just have always wanted to break away from the role that the surgeon is the dominant, and that the surgeon becomes part of a team rather than.
Mark, I think I know what you're saying, and it's about saying just by being the operating surgeon doesn't have to be the lead of that team. It could be somebody else.
Yes,
and then the surgeon could find his role in that team, and that's quite difficult for a lot of surgeons to kind of accustom to, because by definition you become the center point of a conversation within the OR. Jamie, you had your hand up. I'd love to hear what you're saying.
Yeah, so I think I side with Denise in this, that I think it's really important for everyone to have leadership skills and leadership behaviors, whether or not they're going to be the leader of the team. And I think that you are almost never always going to be the leader of groups that you're in. No matter where you go, you might lead one day and the next day you are the follower in that situation. But I tell even our second-year medical students when I'm teaching them that they should be aiming to be demonstrating, you know, at least a novice level of these leadership skills when they're going into our clinical spaces. That's different than being the leader. And so I think that sort of separating out those two concepts of having good leadership skills that you can apply in a variety of circumstances, whether you're the leader or a follower or a co-leader, separate from deciding who is leading this surgery, who is leading today's meeting, really as separate concepts.
Thank you. Nora, you've got your hand raised. We'll come to you.
Yeah, so I would say there's a little bit of both. I think what Mark was describing is what I would label more management. And I agree that doesn't have to be the surgeon. But I do think that at the end of the day, the surgeon has the burden of responsibility for the surgery. And they have a particular expertise that they come in. Now, of course, what we're saying is the decision-making should be inclusive. You know, they need to be able to create a safe environment so their colleagues speak up. They need to be collaborative. You know, they need to be reflective. But I think really for me, it's about the surgeon plays an integral role in framing that environment, because they are the core competencies. They are the person who at the end of the day If something goes wrong, they're the accountable one. And this is why it can be really difficult for surgeons subsequently to give up some of that, authority or power, whatever we want to have. It's not because they're bad people. It's because they do feel a tremendous weight of making sure that things are done correctly. So it is normal. Many of us would feel that way in that situation, and that's why we need training. That's why we need to be able to learn how to trust and develop those teaming skills.
Thank you for that. Jamie, coming to you around another couple of conversations. One is, of course, you teach on innovation. The whole Harvard surgical program is on leadership and innovation. So do surgeons need to be innovators as well? Is that part of what we have to train them, which will then make them also leaders? Is that necessary? Or again, is it only for the few?
I don't know if I would say that it is completely necessary, but I do think that it is really important because surgeons have a really unique viewpoint. They're the people who are in the operation doing the work. And so they see also what the problems are that they're not able to solve with the current equipment. And the struggles that they have there, or that their patients have. A lot of people come up with great innovative ideas around how do we connect to patients post-op or pre-op to make sure that they're getting the information that they really need. And that unique viewpoint is part of what I think we are trying to get at with the surgical leadership program, is that it's not a generic leadership and innovation program for anyone. It's for surgeons, because we want to highlight that unique viewpoint, and we really want to pull out that from that vantage, things that other people don't know, other entrepreneurs don't know about. And so I think that innovation is what helps drive clinical processes forward. And so does everyone need to think about being innovative? Probably not, but I do think it's really important for surgeons to at least be open to the idea of thinking about innovation and technology and where those ideas can take them and where it can take surgery in sort of our new age of AI, machine learning, big data models that we haven't had in the past. There's a lot of opportunity.
The world's changing. I think that's the critical part. From when Mark and I trained many years ago, we didn't have all of these issues to deal with: the technology, the innovation, the issues around equality, diversity, the kind of looking at our metrics and our data to look at performance. They simply did not exist. And so we're now under much more scrutiny about performance, about how we deal with our patient outcomes. So I think you're right. Those general skills are now being quite important. Nora, I was lucky enough to come to one of your talks only a few weeks ago at UCL. It took an example of a Kaiser Permanente as a story of change, etc. Can you share that again with us in the audience? Because I found it a fascinating example of leadership and change.
Yeah, well, this was definitely a great example of someone with a clinical background, a hospital chain, and of course, there's still a very prominent chain, but really who had centered themselves on kind of keeping costs down and then changes in the U.S. healthcare really catching them out, as it were. But I think what's really important in the takeaway for today about that story is the idea of being a clinical leader and being able to tap into your colleagues in a effective manner. And it gets back to, again, Denise highlighted clear communication, that ability to be a great listener, but a great communicator. And also by being a clinical leader, you can show support and empathy for your colleagues in a way that can be very dynamic and very change-making for others around you. So, by having those competencies that Jamie has articulated, that, individuals get on that program, which builds up that business, competencies and skills and capabilities, and then being able to couple those with your clinical background to be an effective leader by using them to really, be that change maker, to build those teams, to have that, what I call adaptable, flexible mindset. In this case of, Kaiser Permanente, it was existential. It allowed them to come back because he was able to tap into the GPs, tap into the way and they were practicing, provide them with a kind of a different view, and they were ready to listen because he himself was somebody who had, essentially, demonstrated his ability of leadership in multiple domains. So I think that's really important to remember that, clinical leadership can take place at various points in our career. And it is, and I'm going to just keep hammering this word, mindset. It's about taking a different kind of mindset, being open to challenge, being open to thinking differently, being open to, new things, innovation. And I think if we can really garnish that into our surgical leaders, wow, what a great future for patients.
Thank you. Thank you for that. Denise, I'm coming to you and ask you a slightly different slant of the question. And often the signs of a great leader is dealing when things go wrong, when it's challenging, with stress, with bad outcomes, with bad teams that are dysfunctional. And that often really brings out leadership in its truest form. Give me a few examples of that. How do people deal when things go wrong, when they have to come into a place that's dysfunctional, for example? Tell me a bit of those experiences you might have seen and how one might go about addressing some of those issues or dealing it as a leader.
I've seen some stunningly bad examples and I've seen some wonderfully successful, good examples. I'm going to start with the negative examples first, and just to see if it hits home with the rest of the group. The surgical leader came into a new department, and we were going to be introducing this new approach and a new process and a new technology. And this surgeon was brought in specifically to implement this change, because the team wasn't functioning well. They had lots of issues in this particular hospital team. And before I even got anything unpacked, he's already rolling up his sleeve saying, right, this is what we're going to do. I'm here now, and we are going to do this way, and this is how I work, and you're going to do this, and already started to push this new technology, this new system, almost before he even introduced me or introduced any of his new team members. In the end, the change was implemented, but I had to go back a number of times to kind of unpick, undo, repair the damage that was done in the first maybe 50 seconds of, it seemed 50 seconds to me, and then it felt like a lifetime of trying to backtrack that first introduction. The good example that I had is in a different country on this side of the Atlantic, and the surgeon was new to our team, and he went about getting to know everybody, saying up front, I'm here because we're going to implement this new technology, this new approach, and I know you've been used to doing things in this way. I would like to learn from you how you've been doing things, what the challenges are. We set up some meetings for him to listen and learn from his new team what was going on, and we set a timetable for changing to the new approach with his team. And that transparency, the good communication, the listening, asking for their objections, what were their concerns, what concerns you most. Doing the risk management together with the team meant that, no, we didn't implement everything in that first week, but we implemented it in roughly a month.
Right.
With less trauma, certainly
Yeah.
on my part,
Great example.
and the team.
Yeah, that's great examples. Mark, back to you. Now, you've had a successful career as a gynecologist in Cambridge. You transitioned and to essentially found a unicorn. For those that don't know, a unicorn is where you take a company from zero valuation to $1 billion, and that's called a unicorn. So Mark has an amazing story in CMR, Cambridge Medical Robotics, really translating innovation and disrupting the world of robotic surgery. So what have you learned about leadership from industry, building a startup, compared to, say, the NHS? What are the kind of the cross-references? And could we learn a lot more by embracing more of the industry kind of ways of working?
Shafi, absolutely. I mean, the one thing, you know, I've done quite a lot of inventing in my career. So the robot's the biggest one, but I've done other things which I've sold to international companies in the past. And I always say to people, listen, no matter how stupid it sounds, until you've actually heard the whole story and you've seen it implemented, you don't know whether your decision about its usefulness is premature or not. So I get approached by a huge amount of people to give me ideas. And what I've learned to do is say, thank you, tell me about it. Let me hear you and let me digest it, because every idea is potentially very positive. In terms of industry, one of my role models is Paul Pullman, who used to be the head of Unilever. And he ran his company with a concept called net positive. Everything you did had to contribute back to the society and the world that you lived in. And I think that's incredibly important. And in my own company, I've done that with the staff. I like them to participate in charities, to give back lectures to schools, et cetera, et cetera. But in terms of the NHS, one of the great worries for me, and I'm going to be controversial here, is many years ago, as one of the heads of the NHS decided that doctors were too independent and decided to bring in people that were more subservient and listening. And one of the characteristics that will get you to a senior leadership position in the NHS is to be known to not disagree with management.
Well, the yes man or the yes woman, whatever you
correct. So
say.
you rise up in the thing and you become the leader. Now, that's not a leader. A leader challenges, a leader thinks differently, a leader looks for different solutions. And the great worry, and in the US, I think it's better. So if you you qualify as a consultant or whatever, you go and work in a hospital for a few years, you make your name, you write research, and then you apply for a head of department status. In the NHS, you get your head of department status by compliance, and that lacks leadership.
Yeah, so I guess that takes a few things that we've discussed recently with the NHS. I'm sorry we talked NHS because Mark and I both work here, of course, here in the UK. We have had issues recently with bad leadership, bad outcomes, also with issues around whistleblowing. So whistleblowing is an area where people are asked openly to, if there are problems, to raise their hands and suggest it to management, etc. But then the issues are whistleblowers often then maligned or kind of disavowed, if you like, almost from an industry. So although the rhetoric sounds positive, Mark, actually the opposite is true.
Yes.
We don't actually accept challenges, don't accept things that might be going wrong. And those are the things we've seen time and time again that have led to poor outcomes. Nora, have you kind of come across these where, for example, we put the framework in about good leadership to improve outcomes, but we failed to deliver because it's just a tick box exercise for our health systems? And so how do we overcome that? Because a lot of people are disenfranchised because they raised their voice and they had this duty of candor, but actually they are then shot down because the system won't simply allow it.
Well, I think, of course, this is a major challenge. And I think one of the other things, and it's a fallacy, it's a myth, and And that is, we've historically often shut those people down by using our policies, our regulations, and processes. And because we've hid behind them as though somehow those make patients safe. But in reality, actually, by not encouraging people to speak up and not speaking up ourselves, we actually put people at risk. And so I think it is, organizational culture and development change is what we're talking about. And we sometimes get change management and organizational development mixed up. But my view is we have to have that organizational development, that culture change. Otherwise, that's part of the reason, by the way, we see so much change management fail in our health system. And it doesn't matter if you're in the UK, you're in the US, you're somewhere else. So I think what we need here, yes, it can be really frustrating. And I've had people say to me, I tried to take it to my line manager, I tried to go here, and sometimes, sadly, people will try to do it themselves. They'll try to, but I want to warn everyone on this call. That's not the answer either. That just adds to the dysfunctionality. So we have to, as leaders, as people who are really committed, we've got to be the ones that step forward and we start to change the culture. And because it can start with just a single person, but there's no reason to keep denying that we have a problem here and not address it, because it can't be done in a bitty way. It really does take system change.
Thanks for that. I'll come to the question in a moment. There's a few questions proposed. Please do feel free to use the Q&A and chat to put some questions up, which I'll post to the panel. The other question for you, Jamie, is how do we look after leaders? Leaders have a difficult position. Sometimes they fail, sometimes they succeed. It's stressful, and a lot of people might find it difficult and out of their depth. How do we look after the leaders who are in clinical practice, for example? You teaching medical students all the way to senior surgeons, for example.
I mean, that's such an important question, and one I think we're still trying to find the answers to. We always bring somebody who is sort of a lifestyle medicine specialist into our leadership course. And they talk to the surgeons a lot about, how are you taking care of yourself? Do you need sleep? You need to eat a healthy diet. You need some sort of exercise. You need to figure out how to manage your stress in some way, shape, or form. And, she puts them through this whole process. And most of them say they're not doing most of those things right now because they're busy with their clinical practice. Most people in our course have some sort of at least small leadership position already that they're in. And it's hard to figure out how you manage those things. Yeah. And I think that is something, at least in the US, and I think this is true in the UK and probably around the world, we're all struggling with, how do we figure out how to run hospitals, run healthcare systems effectively while not burning out the people who are actually doing the work on the ground? Yeah. And I think that's probably one of the biggest dilemmas that's going to be facing our healthcare systems here over the next several years, is that we're losing people who don't want to be in clinical practice anymore because they don't get home at night to their families. Yeah. They're not getting to take good care of themselves. And there are repercussions for that.
Yeah, and that's right. We are losing a lot of people in surgery. You're absolutely right. A lot of people are leaving the profession. It's not as popular as it was before. And we have to think about what role are they going to have in the future? How do we nurture the next generation to be innovative, to have flexibility, to become leaders, to also be good surgeons? And it's much more tricky than it was, of course, in the past. I'll come to some of the questions, if that's okay with you. So Fatima's asked a couple of questions around how can people like me can get into surgical leadership courses who are in the process of getting into the NHS, because coming from a third world country, leadership is a new concept. And it's true. I think we're quite lucky here in the UK that we now have got a well-defined role for leaders, training courses, etc. recognition of people who want to go into leadership. But in other parts of the world, it can be quite rudimentary. So any advice on that? Nora, you might be a good person to advise on that. Someone from coming to the NHS from a low middle income country who wants to understand how to go on a leadership course.
So I think, yeah, you know, and of course, places like the Global Business School for Health have a number of leadership courses. I would also say you don't always have to do a degree. There's wonderful short courses out there. And sometimes, you know, leadership is like exercise. I always use that analogy because if you're training to be a great athlete, you do that, right? You train and eventually you get muscle memory. And it's the same thing with those leadership and management skills. So getting those short courses, small bites of learning, seeing what's offered in your organization, online, and then applying them, you know, keeping a learning log, you know, really reflecting on your reflective practice is so important for leaders, and applying those skills, and eventually it'll start to accumulate. And then of course it's learning by doing. You know, it's not all about just learning. It's actually getting out there, putting yourself out there. You know, whether that's in a volunteer role or in a formal role. And all of that will help you accumulate and develop your leadership skills. So it doesn't have to be expensive. It doesn't have to be some really jazzy course. It's really, as I said, it's as simple as getting out on the street and running down the block and running and running and running every day until you're actually a great runner. Practice leadership and practice it every day, and you will be a great leader.
Thank you. That's really great. Mark, a question for you. At what stage of a standard surgical profession will a surgeon can or will assume a leadership role? So just 2 minutes for this question, Mark, and then we'll go to the last question.
I mean, I think that's quite a difficult one because it depends what sort of leadership you are. So if you're surgical leadership, you know, you're an amazing surgeon, you obviously got to get to the point that you're exceptional, that people accept your leadership in terms of surgical expertise. But that doesn't always necessarily need to be the leader. So there can be other people who may not be the most technically skilled surgeon in the department, but may have the skills to actually manage the department to make it better. And I don't think it's an age criteria for that. I've seen very young, excellent leaders, and I've seen much older, excellent leaders as well.
Yeah, and you grow over the course of a career.
Exactly.
You grow, you change, you evolve. And did people do it at different paces, different levels? All routes are to the top.
I mean, I always give Shafi the example. As a young person, I was a conscript in the army, and I was the senior officer, but the soldiers that were working for me or under me were in their 30s and had been pretty much mercenaries around the world. They were proper soldiers. I was just a joke. And you had to adopt an entirely different leadership to lead this group of people that knew more than I would ever know about what they did, but I was still responsible for their well-being.
And you always offer a role. You may not be in their technical expertise or have the skill sets. You can offer a different kind of role. Might be empathy, might be just for example. It's kind of, you also have a value to what you do. To you, Denise, what's the best leadership style? Dr. Eugene from Rwanda, who's a plastic surgery residency there, is asking, what's best style? Is it authoritarian? Is it democratic? Is it servant? Probably a mixture of all.
The best style is the best style is the one that suits the situation. There isn't one style fits all. So there'll be situations where you need to be very directive. You need to boss the situation because it's a crisis, and you need to say, you're going to do this, you're going to do that. Other times you'll need to coach. You might need to be more supportive. And then other times there'll be with an individual where you can delegate. So the best style suits the situation. That
makes sense. And it's often a multitude of skills required and not just one. I don't think it should be one or the other. You should think how you can simulate all those skills together in the context that you've just described. Jamie, communication is kind of a key element we've discussed over and over again. To be a good leader, you have to have good communication skills, also for patient interactions. How does one go about being taught? So communication skills, I'll tell you why, because we often are quite lucky in the UK. Our medical schools have communication skills built in them, postgrad training, and we're now infused with a lot of communication kind of skills, teaching and learning. But other places around the world aren't as kind of ready for that. So where would someone go and get those skill sets required to be a good communicator? I think that's a really important point. What do you think?
Yeah, I mean, communication skills are so important. On sort of a baseline level, I think we learn a lot from watching other people. So find people that you like how they communicate and that you think other people respond to really well. Figure out what they're doing that other people aren't, or figure out what they're doing and what the people who are doing it poorly are doing, and try to really work on matching their skills. Ask them if they're willing to coach you on them. You give bad news to a patient, and then afterwards they can talk to you about what they think you did well and what you think that you can improve on. And that's probably the easiest way to really work on those in your own environment and make sure that they're also going to be culturally competent depending on where you are around the world. I know that there are lots of courses out there for around, delivering bad news and communicating with patients and things like that. But I do think working with someone in your local environment is going to give you a lot of really good insight.
And the leadership's always often in context. People from around the world are joining. And leadership changes with the culture that you're in, the conditions that you might have in the hospital. It's very flexible. You have to be receptive to what you're dealing with, the ecosystem you're working with, the individuals, and you have to be quite resilient in that sense. So I think all the skills we've taught you are generic, but you have to put into context of what you're dealing with, what problem, and the society you're living in, and the culture within the environment that you're working. I think it's it's a lot more than just saying these skills required. We're now come to the end of our webinar. I'd like to thank, of course, our wonderful guests for spending an hour with us of their valuable time. To, of course, Nora, to Mark, to Denise, and Jamie from different parts of the world. Hope you enjoyed this webinar. Our next webinar will be in July the 18th, where we discuss the world of 3D printing in surgery. We're discussing all the aspects of how we plan surgeries in 3D printing, implants, and how we create a new shift in the way we produce apparatus, appliances, prosthesis, and also how we use those routinely in surgical practice. So join us on July the 18th for the next webinar. Thank you so much, my panel. Thank you for joining us from around the world.